in this ASCO, we presented the data of the CARTITUDE-2, which is a multi-cohort study that follows on the CARTITUDE-1, which has already been extensively reported. As you know, multiple myeloma is a rather rare disease, but the progress in multiple myeloma has been truly outstanding over the past decade or so. There are many new drugs that become available. A lot of it is extremely effective. However, in patients who have progressed after 3 lines of therapy and refractory to lenalidomide, they actually do not have a good prognosis, and even with the new treatment that are being applied. So there is an unmet need for this patient population. So the goal of this study, the CARTITUDE-2, was actually to ask the question of the treatment efficacy if we move this Cilta-Cel, which is a CAR T-cell therapy, from patients who have had more than 3 lines of treatment to earlier treatment settings. So in the cohort of this study, a patient who have had 1 to 3 prior lines of therapy, but they must be lenalidomide refractory. Just as a quick background, Cilta-Cel is a CAR T-cell therapy that expresses 2 BCMA targeted single domain antibodies, and that's designed to confer avidity. CARTITUDE-1 has shown excellent efficacy in patients with advanced disease who have had more than 3 lines of therapy. Here we wanted to see the efficacy earlier in the treatment lines, patients who have had up to 3 lines. But despite that, if I would go into the patient's characteristic that we enrolled on this study, the 65% of the patient on this study has had a triple class exposure, and 20% of that were refractory. 40% actually had penta-drug exposure, and 5 of that were refractory. 40% of patients were refractory to carfilzomib, 10% to, 40% were refractory to bortezomib, 10% were refractory to carfilzomib, 35% were refractory to pomalidomide, and 60% were refractory to daratumumab. So as you can see, they already seen the best drugs, and they are refractory to that. All patients were refractory to lenalidomide, and 85% of the patients had prior autologous stem cell transplantation, and 95% were exposed to alkylating agents. So even though we moved this to an earlier treatment line, those patients were fairly exposed to a lot of drugs and refractory. 35% of them as well had high-risk cytogenetic, including deletion 17p, and translocation 1416 was present in 25% of the patients. So as you can see, this is a fairly refractory population. And despite that, the overall response rate was a very impressive 95%. And 75% of the patients achieved complete remission. And of those, 45% achieved stringent complete remission. The primary goal of this study was actually to assess the MRD negativity. MRD is minimal residual disease. MRD negativity at 10 to the minus 5th power. And of the 4 valuable patients who had their samples available, the MRD 10 to the minus 5th was negative in all of them at the time of the cutoff. It is important to note that even though the median follow-up of the study is very short of 5.8 months, nobody has progressed at this time, but the responses are still ongoing. As you know from the prior CARTITUDE-1, the maximum response is reached at 9 months. So we're not even there yet. And despite that, the data is showing extremely high efficacy. It's important to note that despite this very high efficacy, the treatment was fairly safe. The CRS happened in 85% of the patients, but the majority of the CRS, the cytokine release syndrome, was grade 1 to grade 2. Only 1 patient had a grade 3 and 1 patient had a grade 4. So the CRS was very acceptable in terms of the grade, and the CRS resolved in 94% of the patients by the time we are presenting this data. The neurotoxicity ICANS happened only in 15% of the patients, and there were no cases of movement or neurocognitive treatment emergent adverse events. That was a complication that was encountered early on in the treatment of Cilta-Cel on the CARTITUDE-1. However, when we identified the risk factors, which is high tumor burden, grade 2 CRS, ICANS, or high CAR T-cell expansion, we implemented mitigation strategies such as allowing bridging therapy to reduce tumor burden. We allowed for early and aggressive treatment of CRS and the ICANS, and we recognized handwriting abnormalities as early signs prior even to ICANS. By implementing these mitigation strategies, we saw no movement and neurocognitive treatment-associated adverse effects. So that makes this treatment fairly safe because as you see, the CRS resolved quickly and the ICANS also resolved. So in the absence of movement and neurocognitive events, we can now safely offer these treatments for patients in an earlier treatment setting. So this study shows extremely high efficacy and excellent safety profile. And this represents a paradigm shift in the treatment of multiple myeloma. So we no longer need to let patients continue to progress, experience more side effects, and keep introducing new lines of therapy. We can apply this treatment early on, very safely. 5 years from now, the algorithm for multiple myeloma treatment will be completely different than what we are doing today. We are planning to introduce this treatment early on, even further in the treatment setting for multiple myeloma. We're planning to also run a randomized trial comparing this treatment to the established first-line therapy and show the efficacy. I do believe this treatment will prove to be far superior than anything else we're using today, including the high-dose melphalan and stem cell transplantation. Please remember that high-dose melphalan and stem cell transplantation was introduced back in the late 90s. And at that time, there were no effective therapies for multiple myeloma. So it was a paradigm shift, but that was back in 1996. Today, with all the new agents, all the biologic, all the monoclonal antibodies, the treatment algorithm for multiple myeloma has changed completely, and the role of stem cell transplant comes into questions all the time. However, the anti-BCMA CAR T cell therapy will change that even more and will be a complete paradigm shift for this group of patients.